I can tell what you've had done. Last weekend, I was at a dinner party. Great people, good wine. Someone, frankly, heroically tried to make a homemade focaccia. And across the table, a woman who I had just met was telling a story about her kitchen renovation. And I want to be clear that I have no idea how that story ended, because the entire time she was talking, I was staring at her glabella. The glabella is the area between your eyebrows for those of you who haven't spent a career staring at faces under surgical lighting. Hers were not moving, not like a little frozen. They were geologically still. Meanwhile, her forehead was working overtime and her brows had this little upward flick at the tails that I'll explain later on, because once you see it, you just cannot unsee it. I wasn't judging her. Let me be clear on that. I want to be on the record for that. I was diagnosing her. Welcome back to The Line Eraser. I'm Dr. Carol Eisenstat, anesthesiologist, physician injector, and apparently the worst person to sit across from at a dinner party. Today's the episode that you have been asking for. Yes, I can tell what you've had done. And today I'm going to tell you exactly how. Let's start with a confession about how injectors see the world. So you know how like a mechanic can hear a car and tell you it's an alternator before you've finished parking? So that's me, but with faces. It's not just a party trick. It's pattern recognition that's built on anatomy. And patterns are remarkably consistent because bad work fails in very predictable ways. So let's go region by region. Consider this your field guide. So first, let's start with the forehead that doesn't move. Attach the eyebrows that won't quit. Your frontalis is the muscle that raises your eyebrows. Your corrugators and procerus are the muscles that pull them down and in when you scowl. And somebody who's unskilled treats the forehead like a coloring book. They just fill the whole thing with toxin. So here's what happens. When you knock out the frontalis too aggressively, the brain, it doesn't get the memo. It still wants to lift the eyebrows, so it recruits whatever is left, whatever it can. The result is a forehead that's completely smooth and completely inert, with little compensatory movements that are happening just at the edges. The face reads as slightly wrong in a way that most people can't articulate. I'm going to articulate that. That's a dosing error. The next thing are Spock brows. It's a related phenomenon. It's when the eyebrows pretty much go like that. But it's a different mechanism here. If you treat the central frontalis, but leave the lateral fibers fully functional, the middle of the brows stay down while the tails fly up every time the person tries to show any kind of emotion. It's a peaked, perpetually skeptical kind of look. So Mr. Spock, he wore it well, but most people do not. It's also, and I say this just with love, a 10 to 15 second fix for anyone who knows where the lateral frontalis fibers live. The fact that someone walks around with it for 3 months and tells me that their injector either didn't offer a touch-up or didn't know what they were looking at, that's the reason that patients notice this one. And it's so simple. They just don't look like themselves in photos. They can't quite explain what's changed, but every expression feels different and unfamiliar. And that's usually the first clue. The next one is pillow face. This one is the big one in the filler conversation. So the mid-face, meaning the cheeks and the area under your eyes, it has structure, bone, deep fat pads, superficial fat pads, ligaments. Good filler work replaces specific volume in specific compartments. Bad filler work treats the cheeks like a balloon that just need more air. When filler goes in superficially in large volumes, without respect for the underlying structure, you get this rounded, convex, slightly inflated look. The cheeks don't project, they puff. When you animate the person smiles, the filler bunches up under the eyes and creates that shelf. You've seen it, everyone's seen it. The tragedy of pillow face is that it usually happens gradually, syringe by syringe, with an injector who keeps saying yes. What makes it really difficult is that patients often don't see it happening in real time. The change is incremental. One syringe looks good, another looks good. Then one day you're looking back at a photo from 3 years ago and you realize that you were actually more youthful before all the volume was added. The next is lip filler migration. The lips have a border. It's called the vermilion border. And there's a subtle ridge just above it called the white roll. It's what makes a lip look like a lip instead of a smudge. When filler is placed too superficially or too much of it goes in, the product is too thin for the area. It doesn't stay in the body of the lip. It drifts upward into the skin above the lip. So the white roll begins to blur. The crisp edges disappear. From the front, you get a ledge, the duck shadow, the look of a lip that starts somewhere north of where the lips are actually supposed to start. Here's the thing though, migration is so common now that most people think that it's what lip filler looks like. It isn't. It's what lip filler looks like when it actually goes wrong. The frustrating part is that many people assume migration means that they need filler. In reality, they often need less, or sometimes they need to dissolve what's already migrated before rebuilding the lip correctly. Next, we have the Tyndall effect. Under eye filler in the wrong plane. The skin under your eyes is some of the thinnest in your body. If hyaluronic acid filler is placed superficially there, light scatters through it and it reflects back blue. The faint gray blue tint in the tear trough. It's like a bruise that never heals. It's physics. It's called the Tyndall effect. It tells me exactly how deep that injector's needle was, and which is to say that it wasn't deep enough. Fortunately, in many cases, it's fixable. The challenge isn't correcting it. The challenge is recognizing it before someone spends years believing that that's how under eye filler is just simply supposed to look. So one more for the road, the waxy forehead. Skin that's been heavily and repeatedly treated with toxin over the years takes on this almost smooth, shiny, poreless quality. Combined with zero movement, it photographs beautifully and it looks faintly synthetic in person. It's not a complication exactly, it's a style choice, whether or not the person knew that they were choosing it. So that's the field guide: forehead mechanics, brow position, mid-face contour, lip borders, under eye color, skin texture. 6 channels of information broadcasting constantly to anyone who's trained to receive them. Now, here's where I'm going to complicate everything I just said. The phrase I hear most often in consults is a version of this: I don't want anyone to be able to tell. And the phrase that patients hear most often from the industry is, no one will be able to tell. I want to talk about why that second sentence is the biggest lie in aesthetics, and also paradoxically completely true. Here's the paradox. The work you can clock in, by definition, is the visible work. The frozen forehead at the dinner party, the migrated lip at school pickup. You see it, you register it, your brain quietly files it under Botox or filler, but good work is invisible because it respects anatomy. The woman in your office who just looks rested, the friend who came back looking inexplicably great from vacation. You don't file her under anything because there's nothing to file. She just looks good. So your mental database of cosmetic work is built almost entirely from failures. The successes never make it into the data set, and this is a sampling error, and it warps the entire public conversation. People think that injectables look fake because the only injectables they can identify are the fake looking ones. But millions of syringes of toxin and filler go into American faces every year. If even a meaningful fraction of that work were detectable, you'd be surrounded by obviously done faces everywhere you went. You're not. You're surrounded by faces you never thought twice about. So when I say I can tell you've had something done, here's the honest fine print. I can tell what you've had done badly. I can often tell what you've had done well, but only because I know where to look and what subtle perfection looks like at 45. A frozen face, it's a billboard. A well-treated face is a watermark. You need the right light to see it all. And this is where beauty gets interesting. We talk about natural like it's a universal goal. It isn't. Different cultures, different cities, different social circles have completely different definitions of success. In some rooms, the highest compliment is, "You look amazing. Did you do something?" In other rooms, the highest compliment is, "Where did you get your lips done?" One aesthetic prioritizes discretion, the other prioritizes visibility. Neither is morally superior. They're different languages. The mistake is assuming everyone is trying to speak the same one, which means no one will be able to tell is both a lie and a promise. It's a lie when it's said by someone who doesn't have a skill to deliver it. It's a promise when it's backed by someone who understands that the goal of this work was never transformation. It was always plausibility. So let's go back to the field guide, because every single tell I described in the previous section maps to a specific nameable knowledge gap. This is the part of the episode where I stop being fun at parties and start being an anesthesiologist. The frozen forehead with the compensating brows, that's a dosing and distribution error. Someone treated a muscle without thinking about the muscle it works against. Facial muscles work in pairs and in groups, elevators against depressors. And if you've only ever learned 20 units here, 10 units there off a laminated card at a weekend course, you're treating a diagram. You're not treating a real face. The Spock brow, that's an incomplete understanding of frontalis anatomy. The muscle's lateral fibers vary from person to person. You have to assess them moving in person with expression on that specific face before you inject. Pillow face, that's a failure of structural thinking. The midface ages in a specific sequence. Bone resorbs. Deep fat pad compartments, they deflate. Ligaments stop supporting what they used to support. Restoring that requires placing the right product at the right depth in the right compartment. Inflating the whole cheek because the cheeks were looking flat is what happens when someone learns filler as a product, not as a procedure on a real person. Migration, that is product selection and plane problem. Thin products that are placed superficially in high movement areas will travel. Lifts move 1,000 times a day. So if you don't understand tissue planes and product rheology, the lips will teach you, often at the patient's expense. The Tyndall effect, that is depth, full stop. The injector did not know or did not respect how deep that tissue plane was. Do you see the pattern here? None of these are filler problems. None of these are Botox problems. These products are fine. The products are actually remarkable. These are operator problems. Every tell is a fingerprint left by a gap in training. And here's where credentials stop being marketing language and start being clinically relevant. I've spent years in anesthesiology learning vascular anatomy because in my world, not knowing where a vessel runs can end a life. When I put a needle in a face, I'm not thinking about a diagram from a weekend course. I'm thinking about the facial artery and its endless anatomical variations, about tissue planes, about structure, about what lives beneath the skin that I can't see. You cannot place filler in the right plane if no one ever taught you the planes, if you never been to a cadaver course, if you've never been to an anatomy lab. It's really that simple. And that's uncomfortable. Now for the twist, because this wouldn't be the Line Eraser podcast if I didn't complicate my own thesis in this last act. Everything I've said so far assumes that the goal is invisibility. For most of my patients, it is. But let's be honest about something that the industry doesn't like to say out loud. Some people want you to be able to tell. And they're not confused. They're not victims of bad injectors. They're making different aesthetic choices on purpose. Visible work signals something. Let me say that again. Visible work signals something. We pretend aesthetics exists outside of status signaling, but it doesn't. Clothing signals status, cars signal status, homes signal status. Faces can signal status too. A visibly maintained face communicates that someone invests time, attention, and resources into appearance. Whether you personally like that aesthetic is besides the point. It exists, and pretending otherwise doesn't make it disappear. Visible work signals money. It signals maintenance. In certain rooms, in certain cities, a perfectly smooth forehead and an unmistakably done lip function the way a designer handbag does. The point of the bag is the brand. The point of the face is the work. There's a whole aesthetic Instagram face that isn't trying to pass as neutral anymore. Then couture is trying to pass as something that you found at the mall. Do I personally perform that aesthetic? Not in my lane. My entire practice is built on the watermark, not the billboard. But I'd be lying if I told you that those patients are all being fooled. Yeah, some are, but plenty aren't. They look at the menu and they order the visible option. So the real question this episode leaves you with isn't, can people tell? It's, what do you want them to be able to tell? Invisible work and visible work are both available. Only one of them should be intentional. The accident is the part I can't make peace with. Choose a billboard if you want the billboard, but nobody should end up with one because their injector didn't know they were building it. So back to the dinner party, the focaccia, the kitchen renovation, the glabella. If you've been sitting across from me at some point in your life and you're now doing a rapid mental math exercise, relax. Here's the thing about people like me. If I could tell, I would never ever say it. Not to you, not to the table, not to anyone. What I notice about your face is protected by something stronger than HIPAA, which is the fact that I'm not a monster. That's between me and your glabella. But if there's one thing I hope that you take away from today's episode, it's this. Cosmetic work isn't obvious because cosmetic work exists. Cosmetic work is obvious because someone made it obvious. The products are not the problem. The procedure isn't the problem. The question is whether the person holding the syringe understood the anatomy, the mechanics, and the outcome that they were creating. A frozen face is a billboard. A well-treated face is a watermark. And the difference between the two is rarely lucky. It's knowledge. If you'd like a professional opinion you've actually asked for, consults are open with us at Line Eraser MD. You can find us at lineerasermd.com. You can call our office or follow us at Line Eraser MD on Instagram. So if you've enjoyed today's episode, share it with a friend who's convinced that all filler looks bad and fake. Next time on the Line Eraser, we're talking about teenagers, skincare, and why half the products in your daughter's bathroom probably don't belong there. I'm Dr. Carol Eisenstat. This has been the Line Eraser podcast. Until next time.